Hi, everyone. This is Lori Mantefel. I'm a project specialist here at Medistar, and we will go ahead and get started here on today's webinar. This webinar is the 2018 Modified Stage 2 Attestation Guidance for Eligible Professionals, and then also we'll be providing 2019 Stage 3 preparation information as well. I wanted to thank everyone very much for attending. I am a project specialist here at Medistar, and I handle a number of different clinics throughout the state as it relates to both Modified Stage 2 as well as Stage 3. And today I also have available Bree Ross, who comes to us from the eHealth team over at the Wisconsin Medicaid EHR Incentive Program, and Bree will also be available to present a little bit of information or provide a little bit of insight, as well as answer questions to help answer questions that you may have as well. Before we get started, just a couple of housekeeping requests. I do believe that I muted all lines upon entry, and I will have those unmuted during Q&A. Please feel free, but I do ask to go ahead and place your own line on mute unless you're asking a question during the Q&A portion. Also, feel free to use the chat feature to ask questions as well. I do have some other members of the team who are also going to be watching chat to make sure that we answer as many questions as we can during today's presentation. By asking questions, it really helps to make sure that we're providing you the information you need, and as they always say, if you're asking the question, probably others have the same question as well. So with that, I'm going to go ahead and jump right in. First of all, for those of you who aren't familiar with us, Medistar is the quality improvement organization for the state of Wisconsin. And in addition to our work with the Medicaid HIT Extension Program and the Medicaid EHR Incentive Program, which is now called Promoting Interoperability, we also receive funding through other streams and have a number of other offerings, such as technical assistance that we do provide for the Quality Payment Program, including MIPS. Medistar itself is a team of more than 80 employees that really has a broad spectrum of talent within the healthcare industry, and we have experts in clinical topics, continuous quality improvement, managed care, IT, data analysis, and more. Today's webinar in particular is brought to you through the Health IT Extension Program for Medicaid enrolled providers. If you're not currently participating in the program, please consider joining us formally. We spend most of our time providing one-on-one assistance to healthcare organizations across the state of Wisconsin. We get calls from people who just need help here and there to answer certain questions, to actually sitting down, helping you with attestations. And we really design our services specifically around your health IT needs. We're happy to help share best practices, provide security risk assessments, and assist implementing workflows as well. And I have provided the link if you would like to learn more about our services as well. To get started, the objectives today, I'm going to be presenting you with a high-level review of the Medicaid Promoting Interoperability Program, which has previously been called the Medicaid EHR Incentive Program, or Meaningful Use, including registration and calculating the patient volume. And then we'll be going into 2018 Modified Stage 2 Attestation for eligible professionals, including the required documentation, as well as 2019 Stage 3 preparation. I am going to just say this. For some of you, this may be a refresher, and for others, it may be the first time you see this information. In the interest of time, I will be focusing my attention on changes or areas where we receive the most questions. There will be time at the end of the webinar for other questions on information that maybe I haven't gone over. And I'll also be providing a number of resources, what I call my favorite list of resources at the end of the webinar as well. So with that in mind, I did want to highlight one more time this name change, that now the meaningful use, or the Medicaid EHR Incentive Program, really has been renamed to the Promoting Interoperability Program. And the reason last year CMS made that change was really to reflect the increased focus on interoperability and improving patient access to health information. Although many of the requirements in and of themselves have not seen major changes up to this point, the name change most certainly reflects where the program is going with this focus on interoperability. I did want to highlight a few changes that you'll notice specifically on the CMS website, and that is to get to all of the spec sheets and program information on the CMS website. You'll notice that when you go into regulations and guidance, you will no longer under legislation see anything about the EHR Incentive Program. It will show Promoting Interoperability. And then also once you get there, you'll also notice that change. The content is all still the same. It's just the program has been renamed. And then I did want to review a list of incentive payments that an eligible professional is eligible to receive as long as they meet the eligibility requirements, patient volume, as well as the modified stage 2 or stage 3 measures. This is a question that lots of times we do receive. And the one caveat that I do want to add to this is that an eligible professional does not need to participate in consecutive years. So let's say that maybe you weren't able to participate last year because maybe you hadn't fully implemented your patient portal or you didn't meet a measure. That's okay as long as you began participation prior to, or the last year to begin participation was 2016. So as long as you had participated even in that first year AIU stage, you can still jump in to receive incentive payments. With that in mind, a lot of times we receive questions about finding an EP's attestation history as well as making changes. And this information is especially important for anyone of you who do have new eligible professionals at your organizations. You may wonder, well, did they participate previously? Can I attest for them this year? Registration only needs to be changed if an eligible professional has changed organizations. So when you go into the ForwardHealth Portal, anyone that you attested for last year should already show up in your portal. However, if they don't, or and you do have new providers at your organization, you're going to need to go into the CMS registration and attestation portal to see that participation history, as well as to make sure your EPs are registered. You may also need to take a step back into the INA system, which is the Identity and Access System, to make changes there to connect providers to your organization. There is the opportunity to change from, let's say, the Medicare EHR Incentive Program or MIPS has expired. So if you have someone who previously was in the Medicare EHR Incentive Program, they would not be able to change over to the Medicaid Promoting Interoperability Program. And there is a 48-hour waiting period. Once you make changes in the RNA system, you do need to wait 48 hours for those changes to show up in the ForwardHealth Portal. And one thing that we try to say is do not touch, don't go back in the RNA system because for that provider, because that will then reset that 48-hour waiting period. So it's 48 hours from the last time you've touched that. So something definitely to keep in mind.
Hey, Lori.
Yes, Bree?
I'm going to jump in for just a moment.
Absolutely.
If one of your providers previously attested to the Medicare EHR Incentive Program and you think that they may have switched prior to that deadline, that is also something that that you could ask about, and we could find out whether or not your provider had switched in time, where you might still be eligible to participate in the Medicaid EHR Incentive Program going forward.
Mm-hmm. Thank you, Bree, for adding that. Yes, it never hurts to check, for sure. Here I do have a list of information to have on hand prior to attestation. It really helps out if you have a little bit of a checklist and you have all of this information, because then you can go ahead and complete the entire attestation process for an EP. And that includes your required patient volume documentation, the CEHRT documentation, including the chapel ID number, your security risk assessment documentation, specifically the date and the person who administered the security risk assessment or review, your modified stage 2 dashboard reports, as well as the report on the clinical quality measures that you do plan to attest to. So if you have those all together, then the process should go fairly smoothly for you. A few caveats on patient volume, and this really, I'm not going to go into great detail here, but we frequently do receive questions on patient volume, so I felt it was important to review some of these requirements. First of all, you must use a 90-day period in either the calendar year 2017 or 2018. That 90-day period does not need to be the same 90-day period that you use for the EHR attestation period, so meaning the same 90 days that you use for the modified stage 2 or for the stage 3 attestation. There are two ways to calculate patient volume, and that is individually or as a group. Now, although the methodology is different, the actual calculation is exactly the same. The standard deduction for 2018 program year is 5.33%, which must be applied to all Medicaid encounters unless the provider predominantly practices at an FQHC or a rural health clinic. In that case, you can, if you choose to do so, count in those needy patients, or at a tribal clinic, many times they're known as tribal eligible. And you do need to demonstrate that the individual EP or at the group level meets that 30% Medicaid patient volume requirement. Pediatricians are an exception to that, where there they need to show they are eligible with a 20% Medicaid patient volume. There are a number of great resources that DHS has available. In particular, Appendix A, I have a link there that goes into a lot of detail around the methodologies as well as the calculation of patient volume. Bree, was there anything you wanted to add?
Not to the patient volume. I think when we were talking about CEHRT, we might want to touch on some issues of Greenway products. I know that CMS has issued some guidance on certain Greenway products that are known to not meet that minimum certified electronic health record requirement for this program. If your providers are on one of those affected products for Greenway, we still are going to ask that you begin an application before the March 31st, 2019 deadline for that grace period. So those applications should be completed through the patient volume portion, turn in your CEHRT documentation the way you would, and then when you've started them, don't submit them, just leave them as incomplete, but when you've started them, email our Wisconsin Medicaid EHR Incentive Program inbox and give us a list of all your providers that are awaiting an update for that Greenway CEHRT. And then once there is that update, we can set up a time frame for you to complete those applications. So, and I can answer a few more questions about that when we have towards the end, if anybody needs that.
Thanks so much, Bree, for adding that caveat for those who may be using a Greenway EHR. Very good. All right, so moving on to the 2018 Modified Stage 2 Attestation, it really includes four topics, which include the general requirements, the meaningful use objectives, the required public health objective, as well as the clinical quality measure CQM reporting. And this next slide just basically shows the attestation dashboard page. It looks exactly the way that it has really in the past. If you click on Begin for each one of the four categories, and you can edit these if you need to, and you go back to this general dashboard page in order to do that. We do receive a lot of questions around the general requirements, and so because of that, I did want to sort of put up, first of all, the two questions that are asked as part of the general requirements, and then also just provide a little bit of guidance, because sometimes this trips you up just a little bit. If an EP practices only at your practice and your practice uses a certified EHR, then both of these measures really should be 100%. So the first general question is, please demonstrate that at least 50% of all your encounters occur at locations where certified EHR technology is being utilized. So once again, if an EP is only at your practice, that would be 100%. However, if you do have an EP that practices at multiple locations, because this program is focused specifically on the provider, not the locations, you would need to aggregate those encounters and know whether those other locations were using a certified EHR or not. And there is a tip sheet for guidance that CMS has provided. And then also, and that question is asked two ways, 50% of encounters, and you also need to be able to demonstrate that at least 80% of all unique patients have their data in the certified EHR during the EHR reporting period. And those unique patients well, you can actually use the denominator. If you have an EP that only practices at your at your location, you can actually use the denominator for a number of the modified stage 2 objectives as the calculation of what those unique patient numbers are. I'm going to go ahead and move on. The other thing, and this Objective 0 attestation, this became a requirement back in 2017. So nothing has changed this year, but since last year was the first year, you may have forgotten about this, that Objective 0 supports, shows that you are supporting information exchange and prevention of information blocking. We do have a tip sheet available for that, and this was something that CMS made a requirement last year. You're showing your support for information exchange and prevention of information blocking, and also cooperation with requests from the ONC for direct review of certified electronic health record technology. The good thing to keep in mind with this objective is that you're acting in good faith. You're not expected to be an IT or an interoperability specialist. You're just saying that, listen, to my knowledge, we've got everything enabled. We are not doing anything. We're not doing anything to prevent information exchange. As far as the request for ONC direct review, I'll be honest, none of the practices that we've worked with, we haven't heard of any of these direct reviews. It is different than an audit, as that this would be coming directly from the ONC. But once again there, you're just saying that basically, you know, you would cooperate with that, or you're attesting to having had or had not received a request for that. Our tip sheet goes into much greater detail. And then also the other thing that I wanted to highlight are the clinical quality measures, or the CQM reporting. In 2018, EPs are required to report on at least 6 CQMs. The adult and pediatric sets have actually been removed. One thing that has changed for this year is that an EP does need to successfully, that has successfully demonstrated any stage of meaningful use in the past will need to attest to a full calendar year of CQMs, whereas if this is your first time as a meaningful user or going beyond the AIU stage, you may report on 90 days of CQMs. And the change in this is due to the fact that CMS is trying to align quality reporting across programs. And there really is no change in reporting methodology. I know we have gotten some questions as to if this needs to be reported via a different method, but this would, in the state of Wisconsin, you would continue to report the CQMs directly into the attestation portal as you have in previous years here.
Similarly to that, we did get some questions about, do you need to submit different documentation or additional documentation to support your CQM reporting? The answer to that is that we're not requiring anything additional. We always encourage providers to submit as much documentation as they think supports their attestation, but there's nothing new required of you.
Mm-hmm. The other thing is that for CQMs, there are no thresholds for those, so you don't need to meet a certain percentage in the numerator and denominator, and that has been the same as in previous years as well. And then documentation submission requirements. Once again, there's no changes from 2017. Documentation is required for the following, and this can be uploaded directly into the attestation portal. So you would need to provide CEHRT documentation, the patient volume report, your SRA, your security risk assessment documentation, as well as the modified stage 2 dashboard report, as I generally call it, that specifically shows the percentage-based measures. Now, if you have used an alternate source to calculate those measures, that also should be provided. And there is quite a bit more guidance on the DHS website, as well as, feel free to reach out to your project specialist or to the Medicaid HIT extension program, and we'd be happy to help you with this piece of it as well. And then the document submission methods, these also are the same as last year. Email is the preferred method for groups. And as I mentioned previously, you can upload your documentation directly to the ForwardHealth Portal. In the submission section, the files must be in one of the listed formats there. And the other thing is that the files may not be larger than 2 MB. Or you can, and this is actually the preferred method for groups, is to email the documentation to the EHR program directly. Bree, did you want to comment on this at all?
No, it helps if in the subject line of your email when you're submitting some sort of group documentation that you specify that it is like 2018 attestation documentation, perhaps what it is, and the group name. It makes it easier for us to identify it and tie it back to your applications. And if you do submit as a group in an email, there isn't the need to upload things like an SRA to every single application. Sometimes we see that as well. You can submit things overall as a group and then not have to also add to the application.
Mm-hmm. And then just one caveat on that is to make sure that when you are emailing, especially the personal health information or any documentation that would include personal health documentation, such as the patient, the volume, the patient volume report, or also we recommend the SRA also. Be sure to use encrypted secure email for that. The SRA does not include PHI, but it may contain some proprietary information. And because of that, we do recommend that extra layer of security. Very good. I am going to pause maybe very briefly here just to see if there were any particular questions. Let me see if I can unmute the line, or let me take a look at chat and see if there happen to be any questions there. If you do have any questions, please feel free to use chat as well. Let's see here. All right. I am going to go ahead then and move on to 2019 Stage 3 preparation. And before we begin, I did just want to point out that, first of all, I'm not going to focus on every single objective in Stage 3 today. We are planning a number of additional educational resources on Stage 3 during the year. Today, I really wanted to highlight just a few of the measures and terms that really are new to Stage 3 and recommend some preparation around those. However, as part of the Q&A, I'm happy to address any questions that you may have around that. So let me get started. For program year, the 2019 requirements is that Stage 3 is required for program year 2019 and beyond. Providers must have 2015 edition CEHRT to attest in 2019. If you aren't currently upgraded to 2015 CEHRT, first check the Certified Health IT Products list or the Chapel website to see if 2015 CEHRT is currently available, and check with your vendor to see how to upgrade or when the upgrade will be available. Now, the one piece that I will say is if you don't have CEHRT today or as of January 1st, that doesn't disqualify you for meeting the Stage 3 requirements. Because in 2019, it is a 90-day EHR reporting period, so you will need to report on a 90-day period in 2019 using 2015 CEHRT as well as meeting the Stage 3 objective requirements. And so as long as you do implement CEHRT and meet those requirements for a 90-day period in 2019, you would be eligible, you know, to receive the incentive payment. Now, what's new in this 2015 edition CEHRT? It really has an improved focus on interoperability standards to facilitate the exchange of data, framework for health IT really across the care continuum to help facilitate exchange of data with other settings of care, also enhance patient electronic health information access as well as exchange, and it also is required for both the Promoting Interoperability Program as well as the Quality Payment Program requirements, which includes MIPS and the Promoting Interoperability portion of MIPS. Key changes in 2019. In Stage 3, as I mentioned, there are some notable differences from modified Stage 2. And I'm going to focus on these areas. Objective 5, which is patient electronic access. Objective 6, coordination of care. Objective 7, health information exchange. Objective 8, public health reporting. And then also there are some changes and some additional direction from the state of Wisconsin around eCQM or clinical quality measure reporting, and that you must include at least one outcome or high priority measure. So I'm going to get started with the patient electronic access to health information. For measure 1, you can see that there is an increase in the threshold for patient electronic access. It goes from 50% up to 80%. The other thing that you will notice is that there is an introduction of APIs or application programming interfaces. That is also, for those of you who are unfamiliar with the term API, it's an application programming interface that basically allows one software application to talk to another, similar to when you're booking a flight and you use Travelocity or Expedia. That would be an example outside of healthcare of using API. CMS actually, through their Blue Button 2.0, is developing or asking developers to start to use APIs so that Medicare beneficiaries can see what's covered as well as hook into their patient information as well through APIs. That's just one example. And then measure 2, another difference that you will see there is that there is an increase from 10% of patients to be provided patient-specific educational resources up to 35%, and now that patient education must be provided electronically as well. In objective number 6, coordination of care, two changes to the original stage 3 were that for measure 1 and 2, for view, download, and access, as well as secure electronic messaging, those thresholds will not be increasing for the duration of the program. Both of those measures will remain at 5%. However, what has changed is that in measure 1, it also counts patients who are using an API that would count towards that 5%. The other thing that you will notice with this measure is that although EPs must attest to all 3 measures, they must meet the thresholds for only 2 of the 3 measures. So the first measure is what we know as VDT, that more than 5% of unique patients must view, download, or transmit their health information, typically through a patient portal. But adding to that is another way that they could meet that 5% is to use an API. And it is a combination of the 2 to meet that 5%, as I mentioned previously. For measure 2, that is secure electronic messaging. There's really no change there. More than 5% of unique patients must receive a secure electronic message or send in a secure electronic message and receive a reply. And then for measure 3, it's patient, this also is something new in stage 3, is patient-generated health data or data from a non-clinical setting is incorporated into the EHR for more than 5% of unique patients. And this could be, you know, from a device or from, you know, a patient filling out information that is incorporated electronically. And once again, you must attest to all 3 measures but meet the thresholds for just 2. Moving on to Objective 7, which is health information exchange. Once again, you must attest to all 3 of the measures and meet but you only need to meet the thresholds for 2. In the past, as in the past, there still is an exclusion for all 3 measures. If you recall, if you had less than 100 transitions of care within the EHR reporting period, you could take an exclusion for that measure. One thing I wanted to point out is that now there is still an exclusion, but instead of being able to take the exclusion for an EP with less than 100 transitions of care, the 100 also includes transitions or referrals received and new patients. So therefore, this exclusion may be more difficult to meet for some EPs. So if in the past, under modified stage 2, you were taking that exclusion, when you start to add in those new patients, that may change. But once again, it is for a 90-day period. For measure 1, you create a summary of care and electronically exchange the summary of care to a receiving provider for more than 50% of transitions of care. That is an increase from 10%, so quite significant. Measure 2 incorporates a patient's EHR electronic summary of care document into more than 40% of incoming transitions or referrals received, and patient encounters in which the provider has never before encountered the patient. This is new to stage 3. And then measure 3 is about performing a clinical information reconciliation. So this isn't only medical record, a med rec, but it also includes the current problem list. And that also is for the more than 80% of transitions or referrals received in patient encounters in which the provider has never before encountered the patient, so basically new patients. Objective 8, public health reporting. There have been a number of changes here as well. Measure 1, immunization registry reporting, stays the same, as well as Measure 2, which is syndromic surveillance reporting. That also has remained the same. However, for Measure 3, this one is new, electronic case reporting, which is available in the state of Wisconsin through DHS. Measure 4 is active engagement with a public health registry, and the cancer reporting is available through DHS in Wisconsin. And Measure 5 is the active engagement with a clinical data registry reporting. DHS does not have a sponsored registry. However, if you are a member of a specialty society, you could check to see if there's a clinical data registry available to you as well. And then moving on to the 2019 ECQM reporting, EPs, as I mentioned, are reported to, or are required to report on 6 ECQMs. At least one must be an outcome measure. However, if no outcome measures are relevant, an EP must choose at least one high priority measure. And if no outcome or high priority measures are relevant, then an EP should report on any 6 of the remaining ECQMs. And Wisconsin has recently published and designated the high priority ECQMs for the state of Wisconsin. So Bree, I don't know if you wanted to talk a little bit about those high priority ECQMs.
Yeah, so CMS required, they designated the outcome ECQMs, the high priority ones, and then, the balance of ECQMs that don't fall into either outcome or high priority. States are also allowed to add in additional ECQMs that they designate as high priority. So in addition to the high priority ECQMs that CMS requires be put in for this program, Wisconsin also designated additional high priority ECQMs. We do have the tip sheet on our website, as was mentioned. So essentially, when you go into the 2019 application, the system is being set up in a way that will make this much easier than it sounds to attest to. So initially, what we would expect is that there'll be a list of ECQMs that are labeled as outcome ECQMs, and in 2019, you will need to pick one of those or say that none of these apply to my scope of practice. And then there's the next level where the expectation would be that you then report on a designated high priority ECQM. However, if none of those apply to your scope of practice, you also have the option to say none of these apply to me, and then you would get the remaining balance where you would choose 6 of the other ECQMs. Now, you are allowed to and encouraged to report on more than one outcome and more than one high priority ECQM. And essentially, the high priority ECQMs, the outcome ECQMs, those are used to establish baselines. Wisconsin designated additional ones that are used to establish baselines for Medicaid HMO performance, identify quality improvement focus areas. So we recommend that you attest to as many of those high priority and outcomes ECQMs as you can, because they are beneficial for programmatic purposes. But you are required to attest to the one outcome, at least one high priority, and if neither one of those apply, then the rest. Lori, I don't know, is there anything additional that you wanted to have me add to that? Yeah,
I guess, did you have any direction for 2018? I know that this just came in.
So if If there are high priority eCQMs that apply to your scope of practice that you can attest to, they won't be labeled as such in this year, but we do strongly encourage eligible professionals to attest to those, again, because they do align with our quality strategy. So whenever possible, if you take a look at the sheet and you say, hey, you know, this like CMS 155, weight assessment and counseling for nutrition for children and adolescents, that applies to my scope of practice. CMS says it's a high priority, Wisconsin says it's a high priority. If you can attest to that, we would appreciate it, but it is not required this year. It will be required next year.
You know, and this is the other piece, Bree, just to sort of add on to it, is that, you know, especially reading through the final the final rule as well, there's really an emphasis placed on relevance as well. And so, you know, you definitely want to, you know, choose an outcome measure, then look at the high priority measures. And I think in the vast majority of even specialty practices, you will find some high priority measures that do fit within your scope of practice, but to really try to report on 6 relevant eCQMs as well. So, you know, closing the referral loop is one that I think of as that one is a high priority measure for CMS that applies to many, as well as, you know, CMS 155, the weight assessment and counseling. However, you know, I think what we want to get away from is if you're a dental practice and you are, you know, reporting on cervical cancer screening or something like that, it's obviously not within your scope of practice. And so, you know, you wouldn't want to choose that. There also, you know, you have to look at what your EHR provides as well. So just a couple caveats on that. And then as far as the eCQM reporting period goes, for 2019, it will remain the same as it is this year. So for any EPs who've attested successfully to any stage of meaningful use in the past, they will need to report on a full year of CQMs. But for an EP who has only done AIU in the past, and this is their first year attesting to the measures, they would only report on a 90-day period. And once again, there are no thresholds that are set for these CQM measures. It's just that you do need to report on them. One thing to note is that, because this has come up, well, what if I don't have 2015 CERT, but I have to report on a full calendar year of CQM? That should be possible. In 2018, I would check with your vendor for guidance, but the way that those upgrades have been designed is for you to be able to report on a full year. The same would be true if you were switching EHRs, and most certainly come to us if you do have questions, and we can help you work through those scenarios with your vendor or vendors. Okay. And then this is kind of the recommended immediate actions that we have really as a team here at Metastar, is that number one, if you have not currently upgraded to 2015 CERT, plan the upgrade with your vendor or inquire as to when 2015 CERT will be available, and start to plan that because, you know, you are going to not only have to upgrade, but then also meet those new Stage 3 requirements. Make sure that you also request a workflow guide if you don't already have one, and implement all of the workflows, paying really close attention to those related to objectives 5, 6, and 7, because those are new. And so, you know, they may require some staff training and, you know, some clinical decisions on on how to really implement those workflows. And then begin as quickly as possible running those stage 3 reports and identify those performance gaps so that you can work towards that. Try to do that as early as possible. Also, educate yourself on the new functionality in your EHR, including and in particular how APIs are handled, patient-generated health data, as well as clinical information reconciliation, because those are new. And those may require additional changes in your workflow and as well as some decisions around, how you're going to ask patients for patient-generated health data and such. And then also identify the outcome or high priority ECQMs for your EPs so that you can start to, take a look at those reports and know what you'll plan on reporting on. And then finally, if you are a member of the Medicaid Health IT Extension Program, work with your MediStar project specialist. If you're not, consider joining us. We would be more than happy to help. And then I do have a number of modified stage 2 as well as stage 3 resources. And with that, I am going to unmute the line and take any questions you have, or please also feel free to use chat. And I did just unmute, I think, everyone. Oops, no, it looks like I still need to. There's a number of these. Kevin, also, are there any questions in chat?
Hi, Lori. There are no questions in chat at this time.
Okay. I will. There we go. I believe I have unmuted everyone. Did anyone have any questions or comments that you'd like for us to address? Very good. Well, I would like to thank everyone once again for joining us. I do have my contact information as well as Bree's contact information up on the screen. So if you do run into any issues or questions, please feel free to reach out to us. Thanks again for joining us and have a great day.